computer. Hello, welcome to the AOPT PainCast. In this PainCast, we're talking about occupational and on-site physical therapy and the intersection of pain. Today, I'm joined by two guests, Chris McCallum and Cory Blickenstaff, both physical therapists that work in the occupational and on-site physical therapy settings. I came to know Chris through her work at Coors Brain when I worked in Denver, Colorado, and she's since gone on to just recently write a book called The On-Site Physical Therapist. That's probably backwards, but I said it forward, so there you go. And then Cory Blickenstaff, I've come to know just through the pain world and his role there. So welcome to the AOPT PainCast to the both of you. And to get us started off, I'd like to just ask kind of a general question to help the audience understand what is both let's start with on-site physical therapy, because that might be maybe a niche of occupational health. I know you both specialize that, and then maybe we can broaden the topic out into like occupational health in general.
Or you can start if you'd like.
Okay, sure, I'll give it a go. Thanks for having us on, Eric. Yeah, so on-site, you're right. Yeah, so on-site care is definitely a practice within occupational health, and that is where I practice. So I've been doing on-site occupational health for 15 years plus, might be getting closer to 20 than it is 15 at this point. But so basically what that means is that when I go to work, I drive to a workplace, and my clinic is set up inside of a workplace so that that workplace's employees can come and see me for various reasons. There's different ways that it can be set up. In my particular situation, I have a contract that is paid by the employer. So I am paid for my time there basically instead of by the number of people that I see. And in my situation, I can see people for work-related issues, non-work-related issues, really the gamut. So the idea, the benefit to the employer to having us there in that capacity is that you're trying to encourage a healthy workforce, right? So when people get hurt and when they miss work or when they can't work even up to full speed, these things are very expensive for workplaces. Even if somebody decides that they don't have the physical capacity to stick with the job and move on, even in that situation, that person has to be replaced and the replacement has to be retrained. And there's just a whole lot of expense that's wrapped up into a workforce, and a healthy workforce is less costly to the employer. So that's kind of like the financial reason why it might make sense for a workplace to have somebody to pay the cost to have somebody like us come on site. The potential benefit to the worker is that they've got convenient access to a professional that otherwise they'd have to take time off work to go see, or they just might choose to not see if it wasn't so convenient for them to do. So they've got easy access to a person to a professional that can hopefully help them through some musculoskeletal issues. In terms of kind of more broadly what occupational health encompasses. So in a traditional clinic setting, you're probably seeing more like injured workers. So people who have entered into the workers' compensation system. It might be as simple as just treating that musculoskeletal issue up to and including people that have been off work for long periods of time and are going through more structured programs, like conditioning programs and hardening programs, trying to rebuild capacity to get back into the job that they left, or to build capacity to get into a new job that they, maybe they could not get into the job that they left behind, and they're trying to get well enough and the capacity to make it into a new job. So I'll stop there and let Chris jump in and fill in the spaces.
Oh, you're muted, Chris.
I think you're right.
So for me, on-site has those components as well. I have two main clients, and one client has a big gym and a medical center, and so the physical therapy clinic is in there. We spend a fair amount of time going out into the production areas, learning what the jobs are, um, and then either reporting on those jobs and creating pre-employment testing, or using that information to help someone rehab. And my other client is a food distribution warehouse, and my office is about 10 by 10, has a massage table in it, um, hot pack machine, ice pack, some KT tape, and some TheraBand, and that's about it. But it's right near the employee entrance, so I'm there to greet them when they come in the morning. Um, and Cory already explained kind of the financial reasons that companies would do this, but we are essentially on site for a fraction of a cost that they would, the bill that they would ring up at a PT clinic going through their one of their BUCA providers. So from that standpoint, it saves them money, but really the big saver is getting people where they need to be or preventing injury in the first place. I don't know if the statistic is still true, but I think about 4 years ago, the statistic was 95% of medical money is spent after someone is injured or ill, and it's spent outside the building. And so, really, we're trying to get the money back in the building before an injury, before a big medical issue. So, my day is not scheduled necessarily. Which is kind of stressful when you start out as an on-site PT because you're used to having like I have this patient at 8 and this patient at 9, but it's really easy to fill it up going out and talking to the employees and watching them work and giving suggestions. And in some ways, it's really becomes more like primary care role because you talk to people about things that are not in the PT umbrella, but you have enough awareness as a PT to get them going in the right direction, which is a huge benefit. Um, see what else. So some of the things in occupational health that my company does is we do pre-employment, return to work testing. We do some FCEs. We do job analysis. We do line side coaching or work coaching. We do job conditioning. We do work capacity. What am I trying to say? Work conditioning or work hardening. So we really are trying to get employees everything that they would need to be successful physically at work. And when we talk about occupational health, I think historically people think workers' comp, nurse case manager, disgruntled, let's get them back to work. But I really look at occupational health as people that work. So it's not just people that are injured, it's all employees. And that's really my target for the future. And one of the reasons that I wrote the book that you mentioned, because PTs don't even know this exists. I mean, Cory, I'm sure you've experienced this. You tell somebody that you work at certain client, and they're like, "Oh, I didn't know you could do that." And it's so much better for the employees, and it's so much better for the PTs because we can practice the way that is needed.
Yeah. Do you have a rough estimate? I mean, you guys probably know some of the people in this space, but I'm assuming it sounds like it's not a very big space in the physical therapy world right now. Is that?
I would guess 5% maybe is tapped of employers. I don't know. It's a guess.
No.
Yeah,
And
think that's
go
probably
ahead.
about right.
And, you know, I think when people think, you know, occupational health or even on site, maybe they think like a very manual type job. And I'm wondering if you use these skills both kind of with the workers that have a lot of heavy lifting, but also the workers that are maybe doing less of that, more the traditional desk jobs as well.
Yeah,
I
Yeah.
Go ahead, Cory.
no, go ahead. Go ahead.
I don't anymore. I did as much for people in offices as I did for people in production areas. But my clientele has shifted a little bit. So but it's certainly a valid way to.
Yeah, and I would say in my situation, the places that I'm at are more manufacturing. Some is heavy industrial, and some is more like high tech. and that's a bit of a mix. There's the operators on the floor, but there's also like engineers and a large administrative staff. But I've also done projects at some other places where, you go in and that's more kind of the office setting, and it's maybe kind of a one-off where you're going through and doing job analysis and making some recommendations and things. But I know that there are people that kind of do what we do primarily in the office space, kind of the more office setting. That's just not my particular setting.
Would you say that kind of model is maybe similar to like how a physical therapist might work with a sports team in terms of like the prehab and the components around strength and conditioning, the return to sport in some ways after injury as your role?
Yeah, I think there's definitely a comparison. I mean, you think the team that follows the teams, their job is to try to keep the athletes healthy and playing and on the field and recovering as quickly as they can. I think there is definitely a comparison there. It's just, there's so many other factors that are going on. It's not that it's more. It's just there's different. There is the the injured worker side of it, the workers' compensation side of it, and some of the regulations and things that you have to navigate from OSHA that are probably a bit different. But the idea is the same. You're trying to keep, the person in their occupation productively.
And I will say that there's plenty of statistics that show that when people are away from the work for long periods of time, the longer they're away, the less likely they are to return to work, whether it be workers' compensation or just a standard injury and disability. And along with a huge issue with depression. And so having people to be able to be in the workplace, even if they aren't yet on the floor, they see their comrades, HR sees them, their supervisor sees them, and it feeds a positive forward um, cycle for getting them back to work and having them be successful.
That's great. And there's probably a good point to transition since, a lot of those same things like depression and the mood that come with, an injury often co-occur with pain. And so this is the PainCast. So I'm really curious, because your setting's so unique, I'd like to hear, about how you guys apply some of the modern sort of pain treatments, education or otherwise, in these settings to kind of accomplish the outcomes for both your clients and your employers. And I'll go to Chris first here on this one.
Um, well, I think that I'm not up front with all this pain stuff, but I'm learning. Some of it which I learned from you years ago when we worked together. But I think that the biggest thing I can tell people is that their brain is there to protect them and their brain does not like change. And this is how things heal. And just because you have pain, it does not mean you have an injury. And it's more of a roadmap to help you grade how you're doing to get back to work. So people either ignore pain completely and think it's normal, which I hate to see because I know they don't feel well, or they use it as a hard stop. And so finding ways to make that a guide as opposed to a hard stop is super helpful. In fact, I had a patient last week that he had an ankle injury and then finally required surgery. So he's 7 or 8 months into it at this point, and he's still having pain. And he was walking. And he said, "Yeah, it still hurts." And I finally just said, like I hadn't said it before, I said, "It's okay that it hurts. It doesn't mean that you have an injury or something's injured." And he was like, "Really?" And he's not been the same since. So I obviously need to work on that, but that's kind of where I start.
Yeah, so I mean, as far as pain science concepts, I feel like um, the workplace is just a microcosm of the rest of the world. And so for me, the types of things that have always really kind of resonated with me in pain practice kind of still are at the forefront. So, I really have a strong focus on self-efficacy and autonomy. And those things are very much affected in the workplace. I mean, you get into some of these workplaces where the worker doesn't feel like they've got much say in what their day looks like. And when they are hurt, they feel like their only choice is to grit their teeth and bear it until they can't bear it anymore, or jump into the workers' compensation system. That's not much of a choice. So really, that's where I feel like our skills kind of translate very well into helping these folks, to give them some other options, because really a lot of times, um, a big majority of the cases that people come in to see me in my clinic, they're really just kind of looking for some answers, and they just kind of need some guidance and some information. They're worried something bad is going on, or they're like, I know this isn't the biggest of deals, but I'm not exactly sure what my next step should be. Like, what is safe for me to be doing or not doing? And so really just, I use a lot of the like the motivational interviewing concepts. I still, you know, kind of have that stuff in the back of my mind when I'm talking to people, trying to use open-ended questions and summarize and kind of keep that, the OARS acronym going in the back of my head. I really, I love the expectancy violation aspect, where you're trying to kind of help the person disprove their own kind of worst fear, right? Like somebody comes in with knee pain and they think they've got a broken kneecap, but they're walking fine and they can do steps, and you can kind of help them de-escalate their own thoughts of what's going on. I think all of those things are really kind of the bread and butter of that you find within most pain treatments, and that stuff is definitely at the forefront of what it is we're trying to do.
Interesting.
And
Go ahead, Chris.
I would just say, I would add that education is such a big piece, and they would not get it if we weren't on site. So being able to educate them about their condition is huge.
And how much of that education do you feel like, you mentioned, Chris, you're on the floor, you walk into your work, you don't have a schedule of patients. Sometimes you go out and start walking around and seeing. How much of your education, whether it's specific to pain or maybe related to movement, is sort of that prehab sort of or mentality? I think that's one of the really unique things about this particular setting is, like, you are seeing people in a healthy working environment. Most PTs aren't walking around giving people tips, walking, at the grocery store. I mean, maybe some are, but it's not something that's super common. And I think that's a really unique thing. And so I'm just kind of curious how you guys work that in, or how much that comes about.
You should go grocery shopping with me sometime, Eric. It's hilarious. uh yeah, so I mean, I think you're totally right. I mean, so my wife's also a physical therapist, and she works in home health, and I tell her all the time, it's like I kind of feel like, she's doing like real physical therapy, like she's treating, very sick people, that are dealing with you know big issues, whereas my population are all successfully employed working individuals. And so it's just a different population, but that ability to interact with people when they are well, I think, is where a lot of the longer term impact can come, because you can do a lot of skill building with people when they're well. You're not just trying to get them past the latest issue. You've got the ability to go out and be like, oh, hey, I saw you 3 months ago. I just wanted to see how you're doing. Things are still good. Oh, great. Like, I can we can show you some other things from here, and you can educate supervisors, and you can do all of these things that you just don't have access to. I feel like that rounding, I call it rounds, that on the floor interaction is just vital. I try to get out there every day. Sorry if I jumped in front of you there, Chris.
Oh no, that was perfect. I think that from my standpoint, I really get to use my perception of how people are feeling and their emotions, and um, you can tell when someone isn't, quite right, but they're fine. And so digging into that and saying, well, yeah, are you sore? Or, that sort of thing. Well, that's why I'm here. I'm here to help you with that. This job is going to make you feel that way because it's hard work. But, we can help you with that soreness. I can teach you some things. I can give you a quick massage. And then you'll have the tools to do what you need to do to stay healthy. So come see me. What time do you want to see me? So I can really just um, see the person. I have time to see them, listen to them, and really feel what they're vibing out instead of I'm fine. We know they're not.
Yeah, and that kind of brings up kind of something I noticed when I worked with you, Chris, is like, how you build that relationship so that people are willing to disclose things. Because, you're not necessarily, patients might see you as, you know, part of a reporting process or something, and how you build that sort of trust with the employees, so that they're willing to let you know early on when something's bothering or nagging them, so you can make a corrective change.
Yeah, I'm happy to not be an official part of the reporting process because I think that is a barrier for sure. And so, from my standpoint, they just have to tell their supervisor that they're going to see the physical therapist. And when I have them sign the HIPAA form, if it's not work related, I say I will let them know what time you were here, but I'm not going to talk to them about your condition because right now it's between you and me. So, again, being able to have that position with them. And I've been at both of these places long enough that someone who has seen me in the past, they'll come over leading someone else, and she doesn't speak English, so you just Google Translate. But she said her knee hurts. She heard it playing with her kids, and I mean, it's priceless to have that.
And I would say what I would just add is that the the ability for us to be there on a consistent basis over a long period of time really helps you build a rapport that you don't otherwise have. So like, whenever I've been new in a facility, there is that worry. I mean, people kind of come in testing you out, like, like you're the company doc kind of thing, like, are you here to actually help me? Or are you just here to, to find out what's wrong with me so they can find reason to get rid of me? Like, that's kind of the suspicion sometimes that you'll see. But, um, over time, the rapport builds, word spreads that you're there for the right reasons. And, like Chris said, people start steering people towards you. And then over that course of time, you can really build a cool level of trust that you're just not really going to get to see in a clinic in that way. It's just, you get to a point where you find multiple touch points within the system of a workplace, from employee to supervisor to all the supportive areas like, HR and safety and engineering and all these places. They'll all kind of come to you to ask your advice from different angles of problems. And there's really no way you can get that without going through the process of building the rapport, building your program, and showing that you're there for the right reasons. As an example, you might have a person that comes in with knee pain, and they're there asking questions about what's going on and if it's something that they need more help with. The supervisor might ask you, okay, so let's say this person came back with restrictions from the doctor. The supervisor might need help understanding how those restrictions impact what they can and can't do, right? So they need help maybe translating the functional job analysis, so they make sure that they're helping this person along or not violating any restrictions. The HR person or the safety person then comes to you and says, hey, if this part of this job wasn't as hard as it was, this person could have come back 3 weeks ago. Is there any changes that we could make that would have made their process better? So it becomes this interesting kind of all-encompassing thing that really the the consistency of the presence allows that to happen.
Yeah, that's great. kind of changing gears slightly and kind of going back to pain, one of the patients I've always struggled with, it's kind of paradoxical, but the patient that is really, you have to rein in, they're really, either they don't want to disclose anything because that's just their personality. They don't want to talk about how they're feeling, but they're also just, do they just keep going till they can't? And I feel like you see that in different athlete populations sometimes, but I think you can also see it in that occupational world. And how you both of you have a discussion, um, and motivate these patients to sort of to scale back a little bit. Chris, do you want to take that one, or I see Cory unmuting?
I unmuted.
Okay.
So you're talking about like just the person that's kind of stoic and it's just really kind of hard to get
Yeah.
information from him. Yeah. So, for one, I think kind of creating a safe space is a huge thing. And I think that's true no matter what your setting is. A lot of times that stoicism kind of melts a little bit once a person is um, kind of away from whatever role it is they're portraying as a family member, as a coworker, whatever. So sometimes it's just a matter of some privacy, some permission, not being overbearing in your approach to therapy, being very inviting. But beyond that, I feel like my thing has always been to try in those cases to get whatever it is that we kind of are the path of treatment has a direction, right? We want to get to a certain point, but it's always easier to get there when it's their idea to go there. So, trying to get um, to a place where the conversation kind of becomes they're asking you questions. Um, I've always said instead of hammering explanations at them, that's why I love the expectancy violation approach. You've got an ability to show them something surprising, or for them to show themselves something that they didn't expect, right? Like maybe they weren't able to do, maybe they weren't able to touch their toes, but you ask them to show it to you a different way, and all of a sudden they can. And their first question is like, whoa, why did that happen? I couldn't do that a second ago. Something like that, where their their mindset switches to trying to get to an explanation instead of you just pouring information and lecturing on them. So um, I that's where I love some of the motivational interviewing approaches. I feel like that kind of inviting approach really helps foster that manner of a conversation.
Yeah, I certainly would agree with that. Usually they'll tell you what the deficit is in their life, even though they won't admit it, just by if you get them talking about their family and things like that. I often use automobiles as an example because, especially with the men that are stoic, they treat their cars pretty well usually, and so I just use those examples of high pressure, overuse, changing the hoses, all that stuff. But then I like to, as Cory indicated, get them moving. Oftentimes, um, I need to show someone where a deficit is in terms of movement. Great example is low back and glutes. Glutes are inhibited. So show them that their glutes aren't working while I can show them that mine are, and then say, this is something that we can work on to give you more power and make you move better and that sort of thing. So without hurting their ego, of course, but just showing them some of the pieces, because I think people in that realm are looking only at the whole. And when you're slowly declining, you can't see it. You don't know that you're 30% weaker than you were 2 years ago, that sort of thing. So
Yeah. How do you, um, going back to pain and thinking about pain, how do you think about like other things like sleep and nutrition? Do you guys have conversations about topics like that? Does that seem to be a big part of, these other kind of lifestyle behaviors?
absolutely. Um, We talk a lot about nutrition and inflammation, when they're eating, how they're eating. We talk about sleep, which it's a touchy subject because when you're at a company that works people 15 hours a day, or they switch 12-hour shifts, days and nights every month, I mean, it's a short conversation in that regard because you can't offend the employer. Um, I also talk to them about emotional stability, that it's okay to feel this way if you're feeling down, but it's also important to discuss it and honor it. So those are certainly pieces that I look at, especially when people have had something traumatic. Even I will say it's okay if you feel the need to tear up. That's okay because it's stored in your body and it is a source of stress, and it might be a source of pain. So let it out so you can start to heal.
I think sleep is a very interesting one, especially because some places have rotating shifts, which makes sleep a huge challenge. One of the places where I'm at, they do 8-hour rotating shifts. So what that means is that they've got a day shift, swing shift, a graveyard shift, and they're on that regimen for a few weeks, and then it switches, and whoever was on day shift now is working graveyard, and whoever's working graveyard is now working days, and whoever's working days is now working swing shift, and that process just continues over and over and over again. So not only do you have all of the health issues that come with just working a non day shift to begin with, but you add on top of that that you can't even get used to that. There's no routine that you can ever settle into, and it's really really tough on people's health. And people go through these stages where when they rotate from one shift to the next, they've got like multiple days where they might not sleep for an entire 24 36 hours as they're trying to get their body to where they can sleep for the next round. And that's really, not only is that tough on their body, but it's tough to help them, because there's only so many things that can be done around that deficit. So we talk a lot about sleep hygiene. I tend to use the example of like a bucket, right? Like, your bucket can hold so much, but there's all these things that are filling into it. Your sleep affects how full this bucket is, and what your immune system is doing is filling up this bucket, and the stresses that you've got going on at home are filling up this bucket, and your that fight you got in with your coworker, that's adding to the bucket. And there's, at a certain point, the bucket fills to a point where something's got to give, and that might be a physical, if now your activity level ramps up or something happens to you that your nervous system ramps up, that overspilling might become a physical issue. So in the same way that you've got all these things filling the bucket, there are all opportunities also to remove water from the bucket. So I'll just kind of talk about things in that way. And I'll say, a lot of times, a lot of those things are happening under the surface. I mean, we can't see the state of our immune system unless we're like ill, right? And you don't necessarily see the fluctuating nature of the sensitivity of your nervous system. So a lot of these things are happening under the surface. And same thing with nutrition. I tend to tell people that, like, we like the idea of healthy choices tend to be a good idea. A lot of times people come with a question like, is there some specific nutrient or food or something that I should be eating for this particular condition? And we kind of have this talk that can sometimes be uncomfortable, or it's like, just being healthy is good. And if somebody's convinced that eating magnesium or whatever it is that they love to take is helping them, I don't try to talk them out of that, so long as they're not eating something that's going to hurt them. But you get to have some interesting conversations about what the research says, and what the role of placebo is, and things like this. So we definitely get into those conversations a lot.
So thinking more about pain, I think one of the interesting things too is because some of the people might be coming up to you with ongoing pains. Maybe it's work related, maybe it's not, but maybe they got hurt, going on a hike or exercising or playing with their kids. but now they're at work and they're experiencing pain with their job. How do you kind of educate around, like, to work with pain? Like, when is it time to see me? When is it time, like, how to have that, you know, relationship with, like, how much pain should I be experiencing in this particular task with this job? Chris, I see you unmuting, so I'm going to go to you with this first.
I, that's such a great way to phrase it. How do I work with this? Because most people that get hurt, on the weekend or whatever, want to work. And so I will just explain to them, well, the injury has now happened and now your body's starting to heal. And let's say we use sprained ankle, it's going to swell. You're going to be on it. You want to protect it from going to those big, huge ranges of motion. And when you really start limping, you need to take a break and get it elevated, maybe put some ice on it so that you can move in a fairly normal manner. And every day the swelling's going to go down. Or if we're looking at back pain, if your muscles are so locked up that you can't hip hinge, then it's probably time to take a break. I certainly, with back pain, I talk to them a lot about the fatigue factor of the muscles that are in spasm and the muscles that we're trying to fire. And it's okay that if you go through your little exercises and you try ice and heat, you might just need to lie down for 2 or 3 minutes to let those muscles rest. So I try to give them tools and kind of give them a sense of what the progression will be. So
Yeah, I think that's an important question that comes up a lot in terms of what people are worried about, what's okay to work with and what's not. So there's a couple things. So for one, I do these new employee orientations, and I have this little spiel I go through every time where I talk about how, at one point, if you strained your back, there's a good chance you'd have been put on bed rest for 2 weeks, and you might even been put in traction in the hospital. And they don't do that anymore. And the reason is because at one point they realized that there were people that were kind of ignoring that advice, and those people were getting better too. And the researcher that kind of drove this research is local to me. I'm in Vancouver, Washington. Rick Deo is in Portland. And he did this kind of seminal research that showed that the people that stayed active got better way quicker. And I always say it's like, so they got around to doing this research to see what was the way that kind of was the best way. And it was a landslide victory for the people who kept doing their thing. And I always say, now that's not to say that you should just grit your teeth and bear it and just plow through pain. That's not what I'm saying at all. I kind of explain it. I have this analogy I use. I call it the dark room of pain, where it's like, imagine you are stuck in the middle of a pitch dark room and there's nobody there that's going to be able to get you out. You're going to have to find your own way out of this room. It wouldn't make sense to just stand up and sprint, because you're probably just going to nose plant into a wall or trip over something that you can't see. But at the same time, it wouldn't make sense to just sit there either, because you're not going to get out of the room. You're just going to be stuck. What we would probably do in that situation naturally is kind of start carefully exploring our environment with our hands until we found something familiar, found a wall we could follow, and try to find a windowsill or a door or something like that. I tell people that's kind of the approach we want to take when we're moving with pain. It's not that you just want to ignore it and slam yourself into a wall, but at the same time, movement is good, assuming that you don't have something like an unstable fracture or another reason why you don't want to be moving. And I say this is things that we can help you understand whether or not you need to go get those things checked out before it's safe to move. But so long as that's the case, movement is going to be a good idea for you, most likely. Now, the question is whether or not the amount of movement you can do safely is going to be safe for you to be doing your job. And that's another thing that we can hopefully help them with. I talk about, there's even when we might be going through particular movements together, I might say, it's okay for you to feel it with us, so long as you feel safe. There's kind of two conditions. Neil Pearson's a physical therapist in Canada. He's involved in the the Pain Society's up there. I can't remember like the CPA. I don't remember if it's still called the CPA or not. But anyway, he has this saying where, are you safe now? And will you be safe later? I ask those two questions a lot of times as a guide. I use those as a guide for people. Do you feel you should always feel safe right now, no matter what? And you should also feel like later you are still going to be safe. You shouldn't feel like, now you're not going to be able to move right for the rest of the day, or you're not going to be able to interact with your kids, or you're not going to be able to, finish your day at work. Like, you should be safe now, and you should feel like you're going to be safe down the road. But the challenge is, especially if you're just now starting to get moving with pain, you might not know the answer to that second question, especially until you've done a little bit of trial and error. So, I say kind of err towards cautious to begin with. It's better to find out you could have done more than find out the hard way that you did too much. But in general, it's a good idea to be moving, most likely, with these conditions.
That's great. Brilliant. I've never heard that dark room metaphor. And I really like that one. That's it's a very vivid picture that it paints, and everyone can relate to that experience of waking up in a dark room, in the middle of the night, even their own room, and just really grasp how you have to move in that situation. So I really like that. So I think that's a good one to end on. But before we do, Chris, do you want to explain a little bit about your book here? That's, I think, backwards again on the screen, and where people can buy it, and just what it's about. You mentioned it earlier, but I wanted to give you a chance to.
Sure, thanks. Well, I really found that with my clients where we have entry level manual lifting, manual material handling positions, that the health care and knowledge equity, it's not there. People are health care illiterate, health illiterate. And as Cory alluded to already, people oftentimes won't leave work to go to an appointment. And so that is what struck my heart. And then for 20 years, I've been telling PTs what I do. And they're like, you can work at an employer? I didn't even know that was a thing. And it should be a thing by now. And so I just decided to write the book to PTs so that they understand what it was like for me to get started in this business, and what it looks like to them, and the benefits, and some of the business things they need to think about. And so that was my reasoning for doing it. If they really have never worked in occupational health at all, then there's a resource called the Occupational Health Practitioner Certification, and it's a 3-part course, $700 through the OCSIG that they can take, and then they will know about all of the things that Cory and I mentioned, such as job analysis and FCEs and pre-employment testing and all of those things. And then if they have zero business acumen, there's the direct to employer modules, education modules through the private practice, and both of those are from the APTA. And so hopefully my book is an entry to getting people to understand what it is. And then if they need more education, they have 2 resources that actually came out the same year that my book did. So I feel like there's a groundswell. I'm happy to be in it. People can just go on Amazon and look for the book, The On-Site Physical Therapist, and they can buy it and pass it along. And so thanks for having me.
Yeah. And if someone wants to get a hold of one of you and just reach out and connect with you, ask questions, or, whatever, how can other physical therapists get a hold of you?
My email address is Chris, CHRIS, at McCallumPT.com.
Yeah, email for me too. My email is Cory, Cory, at forwardmotionpt.com. And if I could throw a quick kudos to Chris there. I have read her book, and I would say if you are somebody who's thinking about getting into this space, it'll walk you through it. I mean, you could really start from scratch, and Chris's book will show you she'll make it simple, the things you need to do to be able to get started. It's really good. And I would also say too, she mentioned the certification through the Occ Health SIG. I'm not a certification collector. I'm not somebody who needs to have all these certifications, but I did go through that certification. And even someone like me who's been doing this for a long time, I found it useful to even as like almost like a gap analysis, like, okay, is there anything, have I gotten so set in my ways that I'm not thinking about some of these other things that I could be doing? I found it to be quite useful for that. So yeah, anyway, nice job on the book, Chris.
Thank you very much. I appreciate it.
Yeah, thanks for having me on here.
Well, thank you both. And yeah, just tremendous amount of pearls that you both offered, in terms of clinical insights and kind of bringing a lot of the science to the employer and to the employment space. And I really appreciate that about this and having you both on. And it's been great getting to know both of you throughout, my career. So thank you both. And with that, we'll sign off and we'll see you at the next one.
Okay, thanks.